Well, welcome back to Reclaiming Care. We're really going to be digging into what's happening with our behavioral healthcare system. I'm Don Spencer, and it's great to be here with my co-host, Christine.
Hello, I'm Christine. We've got a fantastic conversation lined up today with Jill Locklear, a mental health professional with a wealth of experience across many different settings. I had so many questions for her in our interview.
Well, and Jill brings such a vital perspective. We'll be touching on everything from how mental health and substance abuse treatment are coming together and how that impacts policy on care, and even the difference and benefits of things like telehealth. It's all about finding out what needs attention.
Exactly. Jill's insights really highlight why reclaiming care is so important. It's about understanding these complex areas from the ground up so we can work towards repairing the system and truly helping people.
This is called Reclaiming Care, and I'm Don Spencer. I'm a retired therapist of I worked over 50 years in community mental health, administration, some fundraising, and private practice. This is our second episode. And Care Restore is to save, literally almost, our behavioral health care system. It's under assault uh, to literally destroy people professionally, personally, and deny care. My co host is Christine, and our technical director is Justin, who was amazing with the technology. And we have a special guest today, a longtime friend, Jill Locklear. We and her husband go way, way back here in our local community. Jill has worked in mental health for almost 20 years. Jill, can you give us a little bit of your experience and background, please?
Sure. I worked the first my career in community mental health settings, first in Genesee County in Michigan, and then down in Atlanta, Georgia. I did a brief stint with the chemical dependency residential facility as a clinical director before I started working almost 10 years at Grady Hospital in Atlanta, Georgia, which is a large community hospital serving the indigent population of Atlanta in the outpatient mental health department. So, and then when COVID hit in 2020, I had just had twin babies and set out to start a private practice doing tele-mental health for
Oh,
therapy.
so you've had a variety of experiences, and one of the things we're looking for is people like yourself, clinicians, fundraisers, administrators, that have a wide variety of ideas, experience, and I'm going to let Christine now talk with you a bit because she has somewhat of a similar experience to you. Go ahead, Christine. You're on.
Jill, welcome, and welcome to our viewers and listeners. My name is Christine, and I have just so many thoughts and so many questions based on your diverse experience, Jill. I'm not really sure where to begin. I guess begin at the beginning. Looking back over your tenure in a variety of different settings and with a variety of different organizations in a variety of states. How would you characterize the impact of policy on the organizations with which you have been employed, like over time?
Right. Oh, that's so interesting because when I was in Michigan, um, it was right when they were starting to really look at comorbidity of substance abuse and mental health and treating them at the same places through the county, and then a nonprofit that I was working at that had county funding. And just saying, like, they don't need treatment in these two different places. Let's get all of their treatment in one place. which I think was helpful for them and really helped them to not, because what was happening was they would go to the chemical dependency place, be denied because they would say, you need to get your mental health treated first, and then vice versa. And I think Michigan was a little early in that advancement because they were just starting to do that then when I moved down to Georgia in 2010, which was at least 5 years later. So that's one area that I feel like there's been some advancement as far as treating the mental health and substance abuse together.
How did you, to come in, how did you find people trying to work together to kind of integrate and pull those different parts of treatment together, say in a multimodal or an integrated
Sure.
treatment? How did
Yeah.
that go? Was it tough for a while or what?
No, I think everyone was really happy to have a team
Really?
approach because you feel so isolated and alone just trying to work on this one section of a person instead of being able to work as a team where what I'm saying isn't contradicting what you're doing and vice versa. It just feels like we're all here coming together to talk about the best for the client. And usually we could sort of agree on how to approach that, and so that we're kind of giving them the same message. And being in a community mental health setting, I think was especially positive because you have the case manager, the psychiatrist, the like therapists all in the same building. And you could just walk down the hall,
Yeah.
be like, this situation came up. Can you call them? You know, at our last session, she said she lost housing, you know, to go talk, refer to case management if they don't already have it. So it already was a team approach, which was really helpful. But I do think, and I don't have much experience with rural settings, but I do think that those are things that are more accessible to people in urban areas.
Oh,
So, Jill, if I may ask, you've had, just a clarification, but you've had experience with highly urban communities and then communities as well. And I believe more recently, if I'm not mistaken, that are more separated more in rural settings.
Well, right now, because I do tele-mental health and I can see anyone in the state of Georgia, I have some clients that are urban and some clients who are in a rural setting that they're so grateful and thankful that their insurance is covering them to see me via video because otherwise they have such limited options in person, you know, in an in-person setting.
yeah.
Maybe, you know, it's their cousin is the only therapist in town, you know, or it's this lady that they've gone to church with their whole life and they don't want to share intimate personal details of what's going on with them. And maybe they even have some concerns about privacy. Like, is what I'm going to say to this person going to get around my small town, you know, in the rural setting? So,
Christine, do you want to follow up there? Or?
Forgive me, I had a little glitch with the technology for a moment. I missed
Okay,
the last
well,
part of it, but I didn't want to interrupt.
well, you've been in private, if I'll butt in here, you've been in private practice for a while. It sounds like you found in the community mental health setting that was the collaboration and team approach was very helpful. And now
yes.
you're kind of pretty much on your own. Is that right? Is that accurate?
Yeah, that is. I mean, luckily, I still have friends and that are licensed clinicians that we can do consultations if necessary. And also, like, I utilize a group that does my billing for invoices with working
Oh,
with insurance companies, and they offer consultation groups as well.
oh,
If you have concerns, they offer clinical consultation, which is really helpful and does help you feel less alone. But I will say, working with the private sector doing tele-mental health, the severity level of the anxiety, depression, you know, I was seeing much more severe mental illness in the community mental health setting than I am private, partly because doing a video telehealth session isn't as appropriate level of care for someone who has very severe mental illness.
Yeah.
You know, let's say they have suicidal ideations. I can't send you to the hospital or write what we call in Georgia a 1013 to send you to the hospital because you need an in-person evaluation for that.
Oh,
So if people
you're
who are
limited.
higher risk
Oh,
need to see
yeah.
people in person.
Oh.
I
So
actually
there's
Christine?
wanted
some
to ask,
limits. Go ahead.
if I may, Jill, I wanted to ask how, when there's the tele-mental health element, do you intervene? Surely there must be crises in your time that have warranted acting immediately with other officials. But how does one negotiate that when you're only on the end of the screen, so to speak?
Right. Yeah, yeah. Well, luckily, I have not had to do that. It hasn't gotten to
Sure.
that severity level. There has been a lot of like crisis safety planning when it even starts showing up, you know. But if it came to that, then what you do is you just tell the person, like, okay, on the video, I'm talking to the police. You always verify where the people are at the beginning of the session. Anyways, you know what? Are you at your home address? Are you at your work address? And then if you need to, you know, not in a sneaky manner, of course, but like, this is what we're doing. We're making a plan for you to go to the hospital. I'm calling, in Georgia, we have a crisis line number, and it has a mobile crisis unit that can go out to the people. So you're not just sending the police, which is really lovely. You're sending a licensed clinician, and they have crisis units with paramedics and licensed social workers that go out. So again, in an urban setting, there's these resources that are helpful. And I'm pretty sure the state of Georgia, I don't know if they have crisis mobile units that go out to the rural setting, but the crisis line and access line is for the whole state of Georgia. So I'm assuming they would. But if they were in an area where there wasn't someone that could go out to them, I would just call the police and stay on with them until that happened, and try to walk and talk them through it and be available to ER staff that needed a consult about what this person's getting sent for. Because it's the police that actually have to write the policy or the order for them to be hospitalized and evaluated for and kind of like on lockdown for 24 hours, you know. So talking about policy, going down that vein, I do think that, you know, the police just need more training in working with mental health people. When I was working in community mental health, a lot of my clients were homeless and they were psychotic. And the police did not know how to interact with them because there was a lot of fear, it seemed. You know, even if they didn't have a weapon on them or whatever, that this person is not predictable.
If you know, that's an important point, Jill, that, and it hasn't come up in our discussions here, that law enforcement is a critical component. Here in our county, I know the Community Mental Health Center used to, and I imagine they still do, work pretty closely with the sheriff's department and the local police departments. Now, if there's training and ongoing consultation, I don't know, but I could see we're thinking of having legal people who understand, you know, the legal ramifications of healthcare and what we're facing, as well as the professionals, lay people, and families involved in this.
Right.
But I'm glad you brought that up about police. I've worked with the local police here, and I, in fact, did some training with them a long time
Right.
ago on suicide prevention. Christine, I jumped in there. You look like you're thinking a lot.
I
She's
am
you.
thinking a lot. There's a lot of good food for thought in this discussion. I'd actually like to jump back a little longer, a little farther back ago, to a conversation you and I had, Jill, before we started actually recording this episode. And in that conversation, you had mentioned, how did you phrase it? I don't remember the exact quote, so I don't want to misquote you. We were talking about
That's
your
okay.
experience in the substance use disorders residential setting. I wondered, I realized that was perhaps some time ago, as compared to today's experience, but if you could make any recommendations to that kind of umbrella of the sector. And by umbrella, I mean, I believe you intimated that it was a for-profit, single-owner residential setting for substance abuse.
I actually think it was nonprofit.
It was nonprofit.
Mm-hmm.
My mistake. I
Yes.
thought the way you said it, it was a for-profit. My experience is predominantly in for-profit. I always kind of have one antennae up for those because I feel like
Right.
they don't always put necessarily ethics of the profession first when they're really operating as a business. But nevertheless, my question stands that if you could make any overarching policy changes or organizational changes to this organization that employed you retroactively, even though it was
Right.
nonprofit, what changes would you like to see?
Man, that's really hard. That's a hard question because I do think that chemical dependency is a difficult, I don't want to say population to work with because I don't want to make gross generalizations that are not sensitive to the clients. But I do think, one, they were attempting to integrate mental health with substance abuse, and that was difficult. They were having a difficult time doing that, which was kind of my role in the clinic. Definitely the primary focus was substance abuse. And they kind of thought of like, oh yeah, we should talk about mental health too, but that's like a side note. And they were dealing with a lot of court systems, people, getting their kids taken away or whatever. And they were just very hard lines. Any like possible, maybe you might be sneaking around, you might be lying to me, you're out of here. It was like, so it felt like it was very chaotic for the clients because they would be like insisting they didn't do anything. It was kind of like working with children who was like trying to figure out if they're lying to you or not. And they just assumed everybody was. So it was like, okay, but this person's kids are going to get taken away from them. They're going to have to go serve jail time if they get released. And there wasn't a clear, the rules weren't clear. They didn't wait for evidence. They just wanted to try to make sure that any possible nonsense going on got out. And that was something that was difficult for me. I had to go I was called in subpoenaed as the clinical director there. And I had to say why somebody got put out of their substance abuse treatment. And literally the CEO had just told me to do it.
Really? Wow.
There was no clear reason. So her lawyer was trying to get me to say there was some sort of bias against the person. And I just kept saying on the stand that, I made sure that the counselor put in the discharge that per the CEO, the client was being discharged. This is a specific situation. But so luckily that's what the note said when they subpoenaed the records. And I was like, I can't speak for the CEO. I just kept saying that. I can't speak for the CEO. You're going to have to subpoena her if you want her to be clear. But I can say that there wasn't a clinical reason as far as I know.
Were you like caught in the middle frequently like that?
And I had to say no to the CEO and the director of clinical services who had no licensure, master's degree. I was the highest person with the license, but she was over me as the VP of clinical services or something. I don't know, forget what her title was. She was basically the CEO's like best friend growing up, So I had to tell her no. She would try to direct me to do things that were unethical, and I would say, I am not doing that. I have a license I can lose, which also puts you on edge because they could fire you at any moment for saying no to them. So But I will say this, in general, the people who worked the program, stayed in the program, had a really good experience. The classes were very good. The counselors were very good. It was just a kind of a difficult place to work as far as toxicity for employees. And I like talking with other people who are in nonprofits that do either just substance abuse or even a mental health nonprofit. I think there's some of that struggle going on. And then it's hard to keep people too, because they don't want to stay in that environment.
So,
Yeah,
yeah,
thank you, Jill. I definitely relate to a lot of the themes that you outlined in your experiences and with those examples. In my experience, professionally at a substance use disorder treatment center, I feel, just a little aside, comforted that I'm not alone and terrified that
Sure.
it's happening all over, or at least two coincidental places. That's really
Right.
disheartening to me. Did I
Definitely.
interrupt you, John?
pardon me?
Did I interrupt you?
No, no.
Okay.
Uh,
Um,
But I will say that was not my experience in Genesee County, working with their community mental health. And that was, I left there in 2010, so 15 years ago. And they had a lot of intensive services. They had assertive community treatment programs, which are very wraparound. They go out to the people's houses. They find them under the bridge where they usually hang out to bring them their medication, to give them their injection. People who are frequent flyers at the hospital trying to stabilize them, who have no family supports, no housing, oftentimes stability.
yeah.
And that program, I will say, if you want to talk about programs that are excellent and need more funding and more widespread in communities, that is such a good modality for wrapping around somebody, because they have a substance abuse. It's a whole team that works with the client. So a different person comes to see them. There's a master's level therapist, case managers, substance abuse specialist, a certified peer specialist, nurse, and psychiatrist, all on the team for every individual.
You sound really excited when you start talking about that. You know?
Yes,
You
I
do.
am. Yeah. And
You really
when I was in, that was one of my first jobs, was supervising a team like that.
yeah.
And you could see how this person who went to the hospital every other month was all of a sudden more stable. And they felt like they finally had support that maybe they didn't have with natural supports in their life.
Well, I'm wondering about staffing and burnout when you have a team approach like that, where you can rely on one
Right.
another, and where there's that kind of
Yeah.
really flattened hierarchy. Everybody's got something to contribute and is valued, right?
Right. Yes. And we
You
literally started every
understand.
morning with a team meeting to
Oh,
go through
wow.
every client. And then everyone got assigned who they were seeing that day. And so let's say one person was really struggling with substances, would be like, okay, why don't we send out our substance abuse specialist because he really needs to talk with you. And then you can take this other person. The nurse would have her list of people that she needed to go give medications to. High risk suicide people they would be seen 7 days a week. So we were going out on the weekends too. We all took on-call hours. So even though it was a team, it was still intense to work there. And I was on call to my staff after hours 24/7 because they were going to see clients after hours, so it was definitely, and somewhat risky. We really could have used a security person for some
Christine,
of our higher risk
You
people.
look like you're, oh boy, that's what I like. I want to
Right.
get into that kind of setting. Is that right?
Right.
For
Well, the
yourself.
reality is that there is risk when you're going into people's homes, you're by yourself, you're meeting them on the street, and they often have psychosis because, again, the unpredictable nature, even if we know them well, you know. But I would say most of the time it was very, it's an evidence-based practice. So it had a high rate of success for people. And then if they did really well, we would then step them down to just a case manager, the case management team, maybe with the therapist, that weren't like as intensive of a team approach.
I've been, Christine, you want to come in there?
Please go ahead.
Oh, well, in our discussion between the three of us, I've been looking at a lot of the public healthcare model, the values and ethics. And public health care, it's amazing the history. Long before community mental health, came in the 60s with President Kennedy getting it started. Uh, but the values and the ethics, and what I see nationally and coming down on the local level, is an attack on those values and those ethics. When you talk to other friends or colleagues now, are they how are they seeing the present situation and what we can do to save and rebuild or protect what we have?
Yeah, that's a good question. I don't know if I have an answer to it.
Yeah, well, it is. I don't know if anyone does.
I
Really.
know, yeah. And I think that there's going to be a trickle down effect, just depending on what was cut with the CDC, what areas were cut with the CDC, what a lot of the experience that I have are places that have county funding, but we know that a lot of the county also is getting money from the federal government, so it might be a trickle down effect that we haven't noticed yet.
Yeah.
And then, of course, right now I'm in the private sector. I do take insurance, but I haven't noticed a big difference with that yet. But I wonder, as Medicaid cuts are coming, as people might not have as easy access to insurance, like I personally use the healthcare.gov website to get my insurance as a self-employed person. I wonder if people are going to have less access to mental health, or if the cost that they come out of their own pocket with is going to change with insurance. But it's just not something that we're seeing yet. These are all just projections of
Well, you mentioned
possibilities.
the other day you have two friends at the CDC office in Atlanta who've just been laid off or fired,
Sure.
right?
Yeah. And those positions were with women's health, reproductive health, and things
Women's
like that.
health.
The not important places of research. So, because
Yeah.
we're female.
Well, you've been very, very telegenic and very helpful in this episode.
Thanks,
Christine,
Don.
would you have any last questions or comments for Joe?
One comment. This will not be my last question, and this will not be the last comment. I look forward to continuing this conversation in more informal capacity down the line. So thanks for
Oh,
coming.
great. Thank you. Thanks for
Yeah.
having me, guys.
Yeah, I know. In our personal friendship, I know you as an articulate person, but on screen you are really articulate.
Thanks.
You say it very, very well, and I, really look forward to more conversation. And if you can think of others that can join us, build this forum,
Sure.
that's what we're about.
Okay,
So,
well, I definitely have people I can reach out to.
many
I'll have my
thanks.
people call your people.
Yeah. Okay. Take
Thank
care.
you.